So I guess in this next little bit here, I just wanted to sort of show that, if the person wasn't particularly able to go into the cross-bracing protocol, there's certainly really good options out there with just a brace-free rehabilitation. And certainly when it comes to ACL healing, we do know, as you pointed out earlier, that there's still a chance that the ACL can get some degree of healing back. So it's certainly not is all lost if we go down this brace-free rehabilitation program too. So this protocol in Eatson 2010, once again, it's widely published and available. I won't spend too much time in particular going through this in terms of exercise videos and prescription, but certainly because it's all spelled out here beautifully, quite well. I think any inexperienced clinician or even experienced clinician can easily pick up something like this and then employ the protocol. It's a wonderful thing. But what I loved about this protocol when I first came across it many years ago is the simplicity of it. It didn't have any fanciness to it, particularly the main strength part of it. Yes, there's some jumping, hopping, and perturbation exercises attached to the program, but definitely the fact that squats, leg press, knee extensions, hamstring curls, step ups, Bosu ball squats are all there that most clinicians should be able to do, or a variation of it in any kind of clinical setting without too much gym access. Of course, if you're going to have gym access and we're going to encourage our patients into really high quality rehab, it certainly does help if you've got that loading. But there are creative ways you can come up with that extra loading at home. But certainly when you're going through ACL rehab, I sort of still feel like most people should be sort of conducting this high quality rehab in a gym setting. But I did love how this program in itself, it really spells out sets and repetitions and frequency per week, all based on the American College of Sports Medicine guidelines for resistance training in healthy adults. I think that's the key there. I think we traditionally underload our ACL patients for no real apparent reason. Like once that knee is quiet and settled, and if we're not, if we're going through this brace-free protocol, then we don't have to be really cautious with these people. We can adequately load them earlier than probably what most people would expect, and the knee can actually tolerate it really well, which was shown in this cohort of ACL patients. So
yeah, and the knee's going to tell you if it doesn't. So listen to the knee. If it's swollen and it's aggravated the next 2 days, then you need to step back a little bit. But the knee's your guide there in terms of how much and when you can take the increased load through the knee.
Absolutely, it's got a great alarm system. So this program, it did introduce some hopping and some landing exercises as part of the protocol. Single leg hops up and single leg up onto a step and single legs back and forth. I think just as clinicians here, I think we just need to be cautious of those in terms of the pain and the swelling. And I think that would probably be my only sort of concern as a clinician. If we've got a big bone bruise on that knee, which often sort of renders the person a little bit sore to impact. I think that's where we might just need to use, once again, clinical reasoning here, is that if we know the person's got an ACL injury, they're holding a bit of swelling, despite the knee being quiet, if you know they've got a big bone bruise there, I'd probably just be a little bit cautious with some of the jumping and landing exercises, but focus more so on the strength work. Certainly bring the jumping and landing stuff in a little bit later, but certainly make sure that the knee is tolerating the strength work first. That would be my only sort of thing there. I don't know, that's probably just my own clinical experience, probably not and there isn't a shred of evidence to support that, but that's just, I've seen people that do jump and land, they get a bit irritated from what I've seen, but that's certainly up to each person that you see, and certainly use some clinical reasoning there when it comes to the jumping and landing exercises here as part of the protocol. You told me some fascinating stories before about the elite level Norwegian, skiers that were doing, Bosu jumps on unstable surfaces, 6 weeks post injury. Amazing stuff. That's amazing what the knee can tolerate, right?
Exactly. But the importance there is that it is a progression. So I definitely warn against taking someone from just squats to suddenly hopping quite early, because if there is instability there, you're potentially putting that person at risk and the meniscus at risk.
Yep.
So it's progression and ensuring they've met the criteria to progress to that next phase, which in some instances may be single leg dynamic work, because you want to get there, but not too early. So you need to
Yeah, it's like anything. I think it's always, for me personally, it's a 2-foot jump before a 1-foot hop.
Yeah, of course.
You got to walk before you run, kind of thing. So that's it's. I think we sometimes get into trouble if we follow blindly, your recipes, and I think that's where I think we just need to really use our really sound clinical reasoning here. And yeah, that would be just my clinical advice there. Is certainly if we're going to bring in jumping and landing with our patients at whatever stage of rehab they're in, yeah, it's to certainly do a lot of lower level things first before you look at those single leg, really high intensity exercises. That's a good example there. 2-foot jump rather than a 1-legged hop.
Exactly. And thinking not only of function and that we don't want aggravation of pain or swelling or other things, and of course stability, but also psychological function.
Yep.
So if we progress through each stage of making sure that they don't have this fear of re-injury or psychological issues with that phase so they can safely progress to the next.
Yep.
I think it's important as well.
Yeah, that's cool. So with the Eaton protocol, the Eaton program, after the 5 weeks of rehabilitation, I actually had 36 out of 100 continue with non-operative treatment following that initial 5-week program. Those that opted for surgery were younger, 24 and a half years compared to 29 for those who elected to continue with rehabilitation alone. And I think this is the fascinating thing, is that program in particular, with the jumping, the landing, the hopping and the perturbation exercises in that program that was conducted twice a week for 5 weeks, there were only 4 adverse events during that time, and those 4 adverse events were swelling and pain. There was no instability episodes experienced on these ACL deficient knees. So yeah, it really goes to show that the knee can withstand and handle a lot more load and impact than what we probably really appreciate. So that was really cool and great that they reported that as well. But yeah, the conclusion here from the authors were that, this 5-week program conducted twice a week led to, in the short term, significant improvements in knee function in patients with ACL injury, both for subjects initially classified as potential copers and non-copers. I think, and beyond that initial work conducted, that's eventually evolved into the Delaware Oslo cohort. What I love is that 5-week program has now been sort of looked at in other ways since then, since that original 2010 paper, and most recently this program in particular has been able to change the coping status of ACL injured patients soon after injury. So the COPA classification, which arguably, whether or not that's something that we all, I certainly have moved away from, COPA screening, but those that are identified as non-copers early became potential copers after just 10 sessions in that 5-week program, which was really interesting, because I think a lot of people early in those early stages of the COPA classification, if they were labelled a non-COPA, they were recommended surgery and not really given a chance to see if they could become a potential coper. So this paper here was quite nice, and this research here was quite nice to show that if you give people a chance, you give them some time, nearly 50% can actually change their coping status. And I'd love to see maybe if they were given more time, maybe if they were given three months at least, maybe even 6 months at least of rehabilitation before deciding on a particular pathway. I think that would be a really nice extension of this research. But but it's nice to sort of see just as little as 5 weeks can change the way a person can feel and function. If we're looking at ACL reconstruction data, that program in particular, when put up against the Moon cohort, where people were had reconstruction once the knee was quiet, as opposed to having a pre-operative period of rehabilitation, which is what the Delaware Oslo cohort have. Those 10 sessions over 5 weeks of rehabilitation resulted in better knee health and function according to the IKDC and Hughes at 2 years post-injury, and resulted in higher numbers of people returning back to sport. So effectively it functions as both a nice rehabilitation program conducted after ACL injury, but also as a nice pre-op rehab program for those going down that pathway. So I don't know if 5 weeks is enough. I think 12 weeks at least would be the bare minimum, and that's certainly what I encourage patients to wait three months. 12 weeks or 3 months, and honestly, I try to drag out as much time as possible before a long-term decision's made. But as the healing cross-bracing protocol research is showing, is that 3-month mark tends to be a good time point to have a check-in to see how are we going here, and what's the pathway potentially going to look like for these people over the next 6, 9, and 12 months. Yeah. Yep. So that takes us to the end of part 3. So hopefully that's sort of given some clinicians, some ideas about rehabilitation to be conducted either in a cross-bracing way, or those that don't want to go into a brace for 4 weeks and go through the cross-bracing protocol. There are certainly really good options out there, but I would certainly argue that 5-week program potentially could go for a little bit longer. That would be my only comment there.
Yeah, good point. Yeah.
Anything you've got to say or add? Is there any, in your experiences working with rehabilitation of ACL patients, anything that we miss as clinicians in the rehabilitation, those early days, early weeks? Is there something there that we should be flagging?
I think physios are usually pretty good at managing the early weeks, in particularly post-surgery. It's the later phases that often people fall short. Unless they're in big sports med centres where they're seeing elite athletes and they've got the gym equipment, often we're under-equipped and we don't push them hard enough or far enough before returning to sport. So I'd say that's where a lot of attention's needed, as well as, again, this maintenance phase. One of the comments I'd make, again, looking back at some of the research on ACL healing and the canoe compared to the brace. So what we're seeing is some people can heal, without a brace and with exercise rehab. What we don't yet know is what is it about these people, for whom might, say, a brace be beneficial and who may actually experience healing with rehab and exercise. Is it to do with the severity of injury? In the future, may we, look towards, say, a more invasive treatment like a brace for those with a more severe injury, displacement of fibres, etc. Whereas, say, a simple mid-substance tear, for example, where the fibres are fairly well aligned, perhaps they're the people that will go on to have a successful heal with rehab. We don't know yet, but I think that's an important question to answer as well.
Yeah, cool. Awesome. All right, we'll have a little break here at the moment. We've finished part 3. We've got one more part to go, maybe another part. We do have another part. We've got 5 parts. We've thrown an extra one at you today. It's going to be case studies and questions, which wasn't on the original slides, but we've got one more to go. And this next one's going to be about return to sport testing through our later stages of ACL rehab with a non-operative management style. All right, we'll be back soon.